Geriatric syndrome, falls. Geriatric syndromes represent clinical conditions common in older adults that share underlying causative factors and involve multiple organ systems. Examples of geriatric syndrome include incontinence, cognitive impairment, delirium, falls, pressure ulcers, pain, weight loss, anorexia, functional decline, depression, and multiple morbidities. Diabetes is considered a multi-system disease. It can affect a multitude of different body systems. Diabetes is the most common metabolic disorder seen in primary care and is a leading cause of cardiovascular disease, renal failure, blindness, and non-traumatic lower limb amputation. Individuals with diabetes are at increased risk for falling due to complications related to the disease on many different levels. One way that diabetes can contribute to geriatric syndrome is through hypoglycemia, which increases the risk for falling. Hypoglycemia is defined as an abnormally low level of circulating glucose in the blood of an individual with diabetes type 1 or 2. Risk for hypoglycemia include duration of the illness greater than 5 years. Comorbid conditions also put the individual at greater risk for hypoglycemia, such as renal and liver failure, CHF, and hypothyroid disease. Hypoglycemia is linked to diabetics greater than 65 years of age with comorbidities that and also those that take a long-acting sulfonylurea for glucose control. Falls can prove statistically significant in many ways. According to the CDC, 1 in 5 falls cause serious injury in older adults and may result in a broken hip or traumatic brain injury. 3 million older adults seek emergency care each year as a result of falling, and as many as 800,000 patients are hospitalized each year due to falling. 300,000 older people are hospitalized each year for hip fractures, and greater than 95% are caused by falling. This is significant according to the CDC because a fall that results in a broken bone can impact an older adult's ability to perform ADLs and IADLs. A fall can provoke feelings of fear and limit an older adult's desire to remain active. Also, a fall that results in a head injury can quickly become an emergency if the patient is taking a blood thinner, as this can also lead to a hemorrhage. This is just some statistical data. Fall death rates in the U.S. increased 30% from 2007 to 2016 for older adults. In this scenario, this is a 73-year-old white female that presented with complaints of a fall 2 days prior after an episode of hypoglycemia upon waking in the morning. A home glucose reading of 52 was obtained. This patient is up to date on flu vaccine, pneumonia vaccine, and shingles vaccine. There are no known drug allergies. She is taking metformin 500 by mouth twice a day, lisinopril 10 milligrams by mouth daily, glipizide 5 milligrams by mouth twice a day, and simvastatin 40 milligrams by mouth every day. Past medical history for this patient includes hypertension, elevated cholesterol, diabetes type 2, anxiety, which she admits is social anxiety, and hypoglycemia. She has had a left hip replacement in 2017. Health maintenance and disease prevention include glucose monitoring, both fasting and random, every day, yearly eye exams, A1C every 6 months, a lipid profile yearly, blood pressure monitoring every day at home, and also daily foot assessments. Typical presentation of hypoglycemia and events leading up to a fall. Physically, a patient may experience increased appetite, trembling, sweating, tachycardia, double vision. They may be pale, weak, have poor coordination, or feel unsteady. Mentally, they may experience confusion, lethargy, dizziness, also poor coordination, drowsiness, slurred speech, blurred vision, seizures, or coma. For this patient, she presents to the office awake, alert, oriented times 3. She has a pleasant affect. She is dressed appropriately for the situation with no signs of distress. She does report having some blurred vision at times. She admits to a recent visit to the eye doctor with no changes in her prescription. She denies having a cold and denies a headache. Cardiovascular, she has no chest pain, no tightness or squeezing. There is some moderate dizziness noted only in the morning time. GI, no complaints in bowel habits with continual occasional constipation. She takes Prune's PRN for this issue. GU, she does have increased frequency at times due to increased intake. No burning with urination. Musculoskeletal, weakness is the most noticeable to the lower extremities first thing in the morning. Neuro-wise, she has occasional confusion with dizziness and lightheadedness. States, I get all mixed up when my sugar is too low. She reports occasional feelings of confusion and dizziness upon waking in the morning. Psychologically, she denies feelings of depression, but has some social anxiety. Sleep patterns are well regulated, no thoughts of suicide. Hematologic, she admits to bruising on her forearms and knees related to the falling 2 days ago and getting out of bed in the morning. Skin tears and bruising are noted to both forearms. Each area is covered with a non-stick pad, silk tape. There's mild pain associated with the wounds. She rates them a 3 out of 10. Physically, again, she's alert and oriented, dressed appropriately, she's well nourished. There's no abnormal findings with her head, no bruising, no hair loss. Perla is intact, conjunctiva is clear, moist. Tympanic membrane is pearly and gray with no bulging. Nose is symmetrical, no discharge, no redness to the throat. The trachea is midline with no deviation. No tenderness upon palpation of the frontal or maxillary sinuses. Neck is soft and supple with no swelling or tenderness noted to the lymph nodes. Heart sounds S1, S2 are noted with no murmur, no JVD, no edema to the lower extremities. Pulses are +2 throughout. Respiratory-wise, chest is a 1 to 2 in dimension. Expansion is symmetrical with no accessory muscles being utilized for breathing. Her rate is even and unlabored at 14 breaths per minute. Breath sounds are clear to auscultation and all fills with no wheezing, rhonchi, or rales noted. GI, the umbilicus is midline with no visible masses or lesions. Appears round. Bowel sounds are normal, active in all 4 quadrants. Soft, non-tendered palpation, and no masses are noted. GU, there's no tenderness to CVA, no distension of the bladder, and no pelvic pain. Musculoskeletal range of motion is intact without deficit to the upper and lower extremities. Tenderness with movement to the upper and lower is noted, and she is moving slow, but her gait is steady. Neuro-wise, she's alert oriented. All cranial nerves are intact, 1 through 12. Psych, she is having some anxiety associated with the fall. She does have some purple and red bruising to the right and left forearms and knees. The skin to the right forearm is positive for a skin tear. It's 2 by 3 inches covered with a non-stick pad and silk tape. The left forearm has a skin tear as well. It's 1/2 inch by 1 inch covered with a non-stick pad and silk tape. Vital signs are good. Temp 97.3, respiratory rate 14. Blood pressure 126/76 with a heart rate of 74. Oxygen sats are 98% on room air. Orthostatics were taken in the office. Lying was 122/72. Sitting 124/71. And standing is 131/78. No signs of a drop in the pressure with those. She is 5 foot 7 inches, weighs about 148 pounds with a BMI of 23.2. Several screening tools were used to evaluate both how fragile she is and her gait and balance. First test was a gait and balance scale in which she scored a 24, making her at low risk for falling. A timed get up and go test was complete, in which she scored less than 12. This makes her at low risk for falling. Also, CAT's Index of Independence and Activities of Daily Living was complete with a score of 8, making her very high functioning and independent. Also, a frail questionnaire was complete. The score was a 3, which made her for a little bit on the frail side. All of these tests are put here with links so that they can be accessed for evaluation. Diagnostically, the patient may need to have an X-ray of the upper extremities or the lower extremities to rule out a fracture. At this time, that doesn't seem to be of concern. She has some abrasions, but nothing that indicates a break. Lab work that may need to be complete: A1C, random glucose, a UA, CMP, CBC, and glucose tolerance tests. The plan for this patient is to monitor the glucose upon waking in the morning. Also monitor the glucose at home every 10 to 15 minutes if hypoglycemia is suspected. Consider discontinuation of the nighttime dose of glipizide. Teach the patient the appropriate treatment for hypoglycemic episodes with administration of 2 to 3 tablespoons of sugar and water for symptom relief. Teach the appropriate diet regimen with high fiber, high protein, and complex carbohydrates. Encourage small, frequent meals. Reinforce signs and symptoms of mild hypoglycemia, such as shaking, sweating, hunger, weakness, and tachycardia for early recognition. Also, increase exercise to 3 to 5 times per week for 20 minutes and monitor carbohydrate intake. Modify home environment through proper lighting and removal of throw rugs for avoidance of falling. Also, provide assistive devices such as a cane or walker for additional balance. Additional education provided to help prevent falls, including installation of handrails, removing clutter from the home, avoid slippery surfaces, and wearing proper footwear. Differential in this case was orthostatic hypotension, which was ruled out through the orthostatic reading. Also pseudo-hypoglycemia, which was ruled out through an accurate finger stick, which showed that the patient was hypoglycemic. Final diagnosis is hypoglycemia, syncope, and abrasion. Challenge and barriers for this patient. The only challenge that I could see was that the patient is occasionally home alone upon waking in the morning. She is typically very compliant. She's willing to try and adhere to the plan for avoiding hypoglycemia. Community resources. There's a community center in town that has silver sneakers exercise classes. This would be good for the patient to work on building strength and to help avoid any sort of falling related to weakness. Community center also provides yoga for strength and balance. There is a dietitian in this town that does diabetic classes at the local hospital. That would be good to just help with the diet and realizing how to avoid both hyper and hypoglycemia. There's a multidisciplinary healthcare team members. One is primary care doctor, also the ophthalmologist, which she sees yearly, and a dentist that she admits she sees every 6 months. So health behaviors. This patient agrees to work on a consistent carb diet and increase exercise for glucose regulation. Education reinforced on the need to maintain daily exercise and information provided on local resources. She plans to check the blood sugar upon waking in the morning. Also, glucose snack within reach from the bed in case of a low reading upon waking in the morning. Life alert monitor is being considered by the patient and her family. Socially, the patient admits to some social anxiety related to the fall, but is willing to try community exercise classes. Economically, Medicare will cover silver sneakers classes in her area, and she's willing to try to attend these classes. Culturally, she has some concerns about being too old for exercise classes, but reassurance was provided concerning her peer group in the Silver Sneakers exercise classes. And legally, she does not have any legal or ethical concerns. Takeaway lesson from this patient is that the aging population is unique because they are fragile and vulnerable. While it's important to control glucose, it's also important to avoid falling in the elderly population. Falls related to geriatric syndrome can be serious and possibly fatal. Because of the health profile of an aging adult, it can be complicated, and it's important to take all aspects into consideration. This patient is now armed with methods to avoid hypoglycemia, build strength and balance through exercise, and modify the environment to avoid falling. Alright, that concludes the PowerPoint.